Well, good afternoon and welcome back, everyone. Thank you so much for joining ONEgeneration Health and Wellness Webinar Week. We're so excited to have you with us and just taking the time today. My name is Niambi Cooper, and I'm the director of ONEgeneration Senior Enrichment Center. We're led by our organization's president and CEO, Jenna Haas. So we will have the layout for our presentation today. We'll have two amazing doctors with us today, and they'll have two different presentations. So we'll have the first Dr. Bawa with us, and he will also have questions and answers after his presentation. So this presentation is being recorded, so feel free to just tune in and then make sure that you can check in. If you do not receive our ONEgeneration newsletter, you can go to our website at onegeneration.org, or you can just give us a call at our office, and I'll place that number into the chat. So I'm so excited to introduce from the amazing team of Southern California Orthopedic Institute, we have Dr. Bawa. And he will be presenting today on walk away from knee pain with robotic assisted knee surgery. So please take over, Dr. Bawa. Thank you for being here.
Yeah, thank you very much for having me, and thank you everybody for taking time out of your day to learn a little bit more about robotic assisted knee surgery. So I'm Dr. Harpreet Bawa. I'm an orthopedic surgeon. I specialize in hip and knee replacement. I just want to start out with a little bit about myself. I'm from the San Fernando Valley. I went to Van Nuys High School. I went to UCLA for my undergraduate education, and then I did a lot of my training in the Midwest and on the East Coast. So I went to medical school at the Case Western Reserve University in affiliation with the Cleveland Clinic. And then I did my residency at the University of Chicago in Chicago, and then did my fellowship at the Hospital for Special Surgery in New York City. So a lot of what I have tried to bring back to the LA market or Southern California market, I've kind of learned from the various places that I have trained before. I'm really excited to be with Southern California Orthopedic Institute. We have three main offices that I work out of, the Thousand Oaks office, a Simi Valley office, as well as our Porter Ranch office. I'll be sharing all my info with you at the end of the presentation as well. And if there's anything that I can help any of you with, or if you have questions, please, always feel free to reach out. So I'm going to dive right in. Arthritis is a big issue in our community. It affects nearly 70 million Americans, about 1 in 3 adults. So either you or probably somebody you know is experiencing arthritis of some sort. It's the leading cause of disability in the United States, and these numbers are only projected to increase. And so this is why a lot of our resources and attention have been turned to how can we better manage patients with arthritis and try to get them through that to restore their function. Knee arthritis is the most common, more common than hip or hand or any other joint. It leads to a lot of work productivity loss, and about 11% of people over the age of 65 have some type of symptomatic knee arthritis. So it is also the most expensive medical condition to treat of all other arthritic conditions. So a lot of time and resources have really been spent on knee arthritis specifically. So patients ask me this all the time, why did this happen to me? Why do I have arthritis? And the reality is, the biggest contributing factor is age and genetics, both things that we can't change. So I tell all my patients, you should blame your parents. It's probably their fault, just like everything else. Female gender is independent risk factor. Activity, high impact activities, or what you might be doing for work or play can contribute to the amount of wear and tear that your joints see. Obesity, which is another issue that we deal with, also the only modifiable really risk factor that we also experience can contribute to knee arthritis. And obviously, if you had a history of previous knee injuries, post-traumatic knee arthritis is also a big issue. So patients, tend to think that arthritis is isolated just to the bones, and the reality is that it actually is a wear and tear condition that involves all of the structures of the knee joint, including the ligaments, the meniscus, all of those structures. So the bone is what we see on x-rays, and that's how we diagnose arthritis oftentimes, but it's more than just what we see in the bony changes that constitute the entire scope of what arthritis is. So patients, with the normal knee have well-preserved joint space, as you can see here in this x-ray. And as the knee starts to deteriorate and wear and tear, you start to see narrowing and bone spur formation. And then eventually patients end up with severe arthritis with some limited range of motion and disability. So just about everybody on this call right now is somewhere between the left and the right. Now, everyone's obviously, it's a spectrum of disease. So, but this kind of encompasses the normal to the most severe. So, in terms of a diagnosis of knee arthritis, it's a combination of things. Okay, obviously radiographs are important. And once you've diagnosed that patients have this problem, it's how do we manage it, right? So we always talk about medications. Non-steroidal anti-inflammatory drugs are typically our go-to medications like Advil or Aleve. We always talk to patients about weight loss. Whatever they can do on that front is going to be of benefit to them. Knee braces can help offload some of the most effective areas. Injections, there's a variety of different injections. Cortisone is the most commonly used. Some patients also benefit from gel or hyaluronic acid injections. And then the last thing that we talk about is replacement surgery or operative intervention. So, a lot has changed in terms of how we manage patients with arthritis, not just on a conservative standpoint, but also from a surgical standpoint. So when you have a patient with severe knee arthritis, they're basically going from an x-ray that looks like this to one that looks like that with a replaced knee. And I think what's changed is pretty much how we get from point A to point B. So I like to emphasize to everybody that, knee replacements are elective operations, okay? We like to exhaust all conservative treatments before we jump to any type of surgery. We want to make sure that patients are invested in the process because there is a significant recovery involved. I want to make sure that they recognize that nobody needs a replacement. They want a replacement. In terms of the way we do surgery, there's still a lot of things that are unknown to us. Okay, we've come a long way in terms of learning what we can do to optimize patient outcomes, to speed up recovery. There's still a lot of things that we don't know, and there's still a lot of things that we don't know. And that's kind of why this entire the way that we do surgery continues to improve and change. The vast majority of patients who have knee replacements are extremely happy, and they do very well. They have a functional knee that's pain-free. If you look at registry data across all registries, if you look at European data, Australian data, you'll find that approximately 10% of people continue to be dissatisfied with their knees. When their x-rays look fine, clinically their knee looks good, it moves well, but the patients are not quite happy. And that has been the focus of robotics and the advances in knee replacement surgeries. How do we capture this 10% of people that tend to be dissatisfied with the outcome? So that brings me to talk about what's new and improved in knee replacement surgery. Are we performing surgery the same way? Patients ask me this all the time. And the answer is yes, we're doing it the same, but we're doing it different. So the general principles are the same, but our execution has improved significantly. So one of the things that we know is that improper positioning leads to early failure. You can look at the x-ray in the center of the screen. Anyone looking at that can say, oh, well, that doesn't look like it's in the appropriate position. And that leads to potentially repeat operations, a much bigger operation, a more invasive surgery, as you can see is what the patient had to get on the right-hand side. The goal for all of our patients is to avoid having to ever do any subsequent operations again. So why does malalignment occur? It's such a simple question. Why would anybody intentionally put it in incorrectly? And the reality is that these things are not done intentionally, but they're more of a result of the surgical techniques that have been previously available to us. So that leads me to a case example of a patient who's a 45-year-old female with a bilateral medial or inside knee pain. She was a school teacher. She was having pain on the inside portion of both of her knees. Her x-rays show her arthritis is isolated to a specific area, and she's a fairly good candidate for partial knee replacement. She underwent bilateral partial knee replacements. We can have a conversation about that at a different time, but I don't encourage anybody to undergo bilateral lower extremity surgery. But these were her immediate post-operative films. And you can see, anyone looking at this can see that the positioning of the components is not ideal. If you follow her through time, at 1 month, you can see that deformity has gotten worse. At 1 year, even worse. And when she came to see us at 3 years, you can see how significant of deformity she's developed. She's now on disability. She's not able to work. She's and having significant issues stemming from her initial knee surgery. So you take a patient who had isolated medial or inside knee arthritis. She had improperly aligned partial knee replacements, and this led to rapidly progressive arthritis in the other compartments of her knee. And she's requiring repeat revision knee surgery. So you have a 48-year-old patient who's undergoing bilateral revision knee surgeries. And so when I came across this case, I couldn't help but ask myself, what should we do to get it right the first time? I mean, how unfortunate that this person had to go through so much when we could have potentially done it correctly from the very beginning. And that's what brings me to talk more about robotic assisted surgery, because the advantage of the system is you're able to get it right the first time, every time. I have a video here that I'd like to share with everybody, and then I'll talk a little bit more about the robotic assisted surgery.
One possible treatment option for
Dr. Bawa, is there sound? I can't hear anything.
One second, let me, I apologize for that. Can you hear it now?
No sound.
All right, I'm sorry about that. Not sure what happened.
knee pain. It's totally
It's back. I don't know. It starts and then it stops. So it's not.
technology, and it's cheap.
Oh, maybe it's just turned down. Yeah.
I can. So the biggest strength of a robotic assisted surgery is the preoperative CT scan that allows me to generate that 3D model of the knee. So I can basically see what the post-operative result is going to be preoperatively. And what I like to emphasize to patients is the robotics is a tool. It's not an implant. The implants that I'm using have good data supporting their use. I'm not worried about a recall or any issues like that with the implants. I'm just utilizing a tool to place those implants in the more optimal position. So robotics has revolutionized the way that we do knee replacement surgery. It's a tool that allows us to formulate personalized surgical plans for our patients, and it allows me to better take care of my patients and offer some patients surgery as an option that may not have been able to been treated previously. I'm going to open it up for some questions here. These are just some patients or some people, not my patients, who've had knee replacement surgery. So this is my email address. If you have any questions, please feel free to reach out to me. If you'd like to schedule a visit, you can contact us either by phone or there's also a contact portion on my website, bawajointreplacement.com. Thank you so much for your time. So I'll take questions now, Naomi, as if there's any that have come through.
Thank you, Dr. Bawa. We do have a question. Is this covered on Medicare?
Oh, great question. So yes, it is. So the biggest portion of my patients are Medicare patients, and so the Medicare sees robotics as the future as well, and they are obviously dealing with a ton of patients who have knee arthritis. So absolutely, yes, it is covered.
If anyone has any additional questions for Dr. Bawa, we have the chat box. We can raise your hand, and that way you're able to verbally ask him a question.
And my email is on there as well. If any other questions come up, please feel free to reach out to me. I'm really good about getting back to you. And so you can contact me that way too.
Thank you so much. I'm placing this into the chat, your email, so that anyone will also save the chat for later in case anyone has any additional questions, and they can always watch this video over again. And also, I believe we had a little bit of sound error in there, but it's okay because this video is on the website. So we can provide that address for that website for you so that you can go ahead and watch multiple videos that Dr. Bawa just presented on. So if you have no questions, such a great presentation. Thank you so much, Dr. Bawa.
Yeah.
We really appreciate you for everything. And we're going to have our next doctor here.
Great. Thank you very much. Have a great day.
Thank you. Hi, Dr. Ferkel.
Hey, everybody. How are you?
Good. How are you?
I'm good.
There you
Thank
go.
you. Thank you for having me on this afternoon, and welcome to all of our guests today. So I didn't have a chance to ask you beforehand, but are we okay showing some anatomy and open surgical pictures or no?
For sure.
Okay. So that's what I'll do, and then I'll get started by sharing my screen right now with you guys.
Looks good.
Okay, all right, great. So welcome everybody. My name is Eric Ferkel. I'm an orthopedic surgeon here at the Southern California Orthopedic Institute in Los Angeles, California. A little bit about myself. I also grew up in the San Fernando Valley in Sherman Oaks. I went to high school in North Hollywood and went to undergraduate at Washington University in St. Louis, where I played Division III college football. I then went on to medical school in Chicago, Illinois at Northwestern University, and then came back to Los Angeles to USC and LA County Hospital, where I did my orthopedic surgery residency training And that also involved my pediatric orthopedic surgery training at Children's Hospital LA, and then my rehab training as well at LA County Rancho Los Amigos National Rehab Center. After that, I made the decision to do 2 fellowships. I went to my first fellowship in Boston, Massachusetts at the New England Baptist Hospital, as well as at Boston Children's Hospital, where I also spent time as the assistant team doctor for the Boston Celtics, as well as for all the Harvard University athletics teams, specifically their football, lacrosse, basketball, soccer, and ice hockey, taking care of college athletes as well as professional athletes while I was there, spending time learning and training with some of the world's leaders and experts in shoulder and knee arthroscopy. I then went on to a second fellowship at foot and ankle surgery at the Ortho Carolina Foot Ankle Institute in Charlotte, North Carolina, followed by a subsequent study in stem cell research in Amsterdam, as well as the University of Iowa. That's me in the bottom right-hand corner, taking care of the Boston Celtics and Brad Stevens' first year. And then I came back to Los Angeles and joined SCOE in 2015. So before I jump to that, just a little bit more, my offices currently are in Porter Ranch as well as Van Nuys. My Porter Ranch office is right off the 118 and Rinaldi. And then in Van Nuys, we're down in right off the 405 and Van Owen. And as Dr. Bawa mentioned, we treat patients from birth until 120 years old and older, if there are any out there. And you know, a lot of my philosophy in taking care of patients centers around getting people back to doing what they want to be doing and being active, staying active, and being as pain-free as you can possibly make them. My practice is focused on the sports medicine injuries, as well as non-operative management, as well as operative management of both knee pain, foot and ankle, and trauma-related injuries. So what does that mean? That means managing meniscus tears in the knee, ACL tears in the knee, surgically as well as non-surgically, and then treating knee arthritis with non-operative management with biologic injections, such as what Dr. Bawa mentioned, hyaluronic acid or platelet-rich plasma. And then in the foot and ankle, treating sports medicine injuries such as Achilles tendon ruptures, chronic ankle pain, ankle arthritis, ankle instability, broken bones in the foot and ankle, and the list goes on from there. So today I'm going to talk a little bit about common foot and ankle injuries that are sports related. I think one sport that I've seen have a huge growth popularity recently is pickleball. Although the next slide is not a pickleball injury, it's an injury that I see in pickleball or paddle tennis and a lot of other sports that our seniors are playing, which is a golf related injury. And so this is a golf related injury of a golfer who was so excited that he hit a hole-in-one at the Masters of all places that he sprinted down the fairway and arms in the air, so excited. And then, wait for it, there he goes, twists his ankle and there he goes, pushes back in place. Now, the injuries that I see are not always this extreme, but the idea is that the ankle roll, the ankle sprain is a common injury that I see in my office a lot. And the patients can present oftentimes with swelling, pain on usually the outside of their ankle, and black and blue, which we call ecchymosis. Usually x-rays are normal, but occasionally you will see a small fleck fracture. MRIs will often show complete rupture of some ligaments. And what does a sprain mean? Well, a sprain means that you have micro tearing of these ligaments, which where my arrow is. This is the outside of the ankle. This is called the anterior talofibular ligament. That's the most common ankle. Can you see my mouse okay? Okay.
Can't see your mouse.
Oh
yeah, now I see it.
Okay, so that's the most common spot, and this is a very common injury. 2 million injuries of this alone in our country, aggregate of almost $2 billion spent on treating ankle sprains. That's a lot of money, right? And this is most commonly seen in basketball. We see also football, soccer, tennis, tennis of all types, whether it's paddle tennis, racquetball, pickleball. And it's pretty equivalent whether it's male or female who have these injuries. So we then talk about the different types of sprains. There's grade 1, 2, 3. And I would say that, you know, as it sounds like the higher number it is, the more painful it can be. And The sprain in a biologic sense means that you're having micro nano tearing of that ligament there. And sometimes it can mean a complete tear, sometimes it can mean a partial tear. And the more tearing of those ligaments, the more oftentimes it takes to recover. So patients come to my office, their ankle may feel more unstable. They oftentimes may have some findings in their ankle suggesting that there's more chronic pain or other injuries going on here. Here's what the anatomy looks like. Again, where my mouse is at the number 8 right here, that's the most common ligament sprain. This is a high ankle sprain where my mouse is currently. And then down here is considered a lower ankle ligament sprain. These are the more common ones, are the lower ankle ligaments. So how do we take care of these patients? Well, initially it's going to be ice, rest, bracing, occasionally a boot as needed, depending on the type of sprain it is. Working on physical therapy on not just ankle strengthening, but I also believe in what's called kinetic chain strengthening. So getting your hip, your butt, your core stabilized, and getting proprioception back, which is training your body to walk again after this kind of injury. And then for my older patients, I really think it's important to focus on fall prevention. So getting our balance strong again and really preventing a second injury occurrence down the road. For patients where this doesn't improve and they have chronic instability or their feeling of their ankle is constantly given out, then we will consider surgical management. And surgical management can include stabilizing the ligaments. However, if down the road the ankle is not taken care of, you have chronic instability, it can lead on to arthritis. So when I treat an ankle instability, the goal is to fix the ligaments, tighten them back up, and occasionally I'll augment that with something called an internal brace as well, which kind of functions as a seatbelt. Typically, post-operatively, we'll get patients walking pretty quickly and into physical therapy and onto sports, usually by about 4 to 6 months. Now let's discuss another type of ankle injury that I see a lot of, and this is a nice video clip of this, and it being basketball playoff season. You can see the Charlotte Hornets player coming down, and boom, he plantar flexed me, he put his toes down, and feels a pop in the back of his ankle. And the most common injury when you feel a pop in the back of your ankle is an Achilles tendon rupture. And you may have heard of this. Kevin Durant had one last year. Klay Thompson had one last year. It's a very common injury in our elite athletes, but I also see this in my older patients as well. And remember, maybe Kobe Bryant also had one several years ago as well. So people usually come to my office and say, hey doc, I was playing tennis and I felt like somebody kicked me in the back of my leg. I turned around and nobody was there. And that's most oftentimes going to be an Achilles tendon rupture. And so this is what the Achilles looks like when it's torn, is the tendon in the middle here, where all the black and blue and blood is around there. And that's where it's been torn there. And the reason why it's most commonly torn there is because it's an area of our body that does not get great blood supply. When patients come to my office, not only is the story the most important thing, but also the exam is as well. And oftentimes you'll see the patient with a palpable gap, a defect where the Achilles tendon should be. And then you can squeeze their back of their calf. It doesn't move properly. And that shows that there's no attachment from the calf muscle down to the foot. Now, occasionally, sometimes you may need to get an MRI on this if you're concerned about other things going on and it doesn't have the full picture from just the exam by itself. So the goals of treatment of an Achilles tendon rupture really depend on what the patient's goals are in terms of getting back out there. And so surgery has a lot of risks to it. There's blood clots, there's nerve injury, wound complications, but there's also a high risk of re-rupture of not repairing the ligament, or sorry, not repairing the tendon. For my older patients, I tend to treat them non-operatively, and there's some really good evidence that treating them non-operatively can get patients back to full strength and full activity to doing things you want to be doing. When somebody who comes to my office who has either a chronic rupture or something that is really wanting to get back to a certain level of sports that requires a lot of push-off strength, I will guide them more towards surgery. So again, this is, for me, it's tailoring the treatment to the individual. I can, I think, skip through this right here. This really talks about some of the most common literature, but I just want to point out the way that I like to approach surgery for my higher level athletic population is I like to do it minimally invasively, and that is making approximately a 3 centimeter incision. I use a percutaneous guide to pull my sutures through. And then at the end of it, you tighten them all up, and the result shows you this small little incision back there. I sometimes will augment that with biologics as well. Here's what the wound looks like. And you can see how beautiful that all looks when it's closed and healed up. Oftentimes my therapist will tell me it looks like a sock line. You're not even sure where the incision is. And by minimizing this incision, it really decreases wound complication rate and helps get patients back going a lot more quickly. And there's 1 week post-op, and then there's 12 weeks post-op. And again, it's really difficult to even find where that incision might be. So I'm going to want to touch on two of the most common injuries I see: ankle sprains and Achilles tendon ruptures. And now that we're kind of at our time, do I have time to go through one more example of injuries, or okay? All right. So I'm going to go through my last topic that I see a lot of in my population, and that is cartilage injuries inside the ankle. And this can come about from a chronic ankle sprain. It can come from an acute injury. Patients will come to my office with a cartilage injury inside their ankle, and the symptoms will usually be described as clicking in their ankle, occasional pain, swelling, and then you'll get an MRI on it. And the MRI, which is what this picture is right here, will show this darker defect in the center portion of what's called the talus. So just for anatomy, this is the outside portion of the ankle. This is called the tibia. Here's your medial or inside malleolus. Here's the outside of the ankle. This is called a lateral malleolus, called a fibula. And then here's the bone that is the main center pivot of which the ankle rotates on, and this is called the talus. And that is covered with cartilage in the same way the knee is covered with cartilage. You can injure the cartilage in your ankle from a sports-related injury, and you can even sometimes knock off a piece of that cartilage. And so our options to treat this are multifold, and it really stems from what is the size of the lesion. And so occasionally you may want to approach it non-operatively. You want to cast them, boot, watch and wait and see how other people are resolving. If it gets more painful, if it gets more chronic and continues to cause more symptoms, the options then grows from there how to approach it surgically. And this is where I evolve a lot of my biologic treatment. What that means is I like to augment my treatment strategies using what's called platelet-rich plasma, which is your own growth factors from your blood, or what's called bone marrow aspirate construct. And that's true stem cells from your hip bone that I then spin in my centrifuge in the operating room and then add that to augment the healing. And so the goal behind this in the terms of cartilage restoration or regeneration is what I call the holy trinity of sports medicine cartilage restoration. And that's adding growth factors, which are coming to you from the local area. You have a scaffold, which I will provide and bring sometimes cadaver cartilage into the ankle, and then your own stem cells. And that trinity helps to restore and regenerate cartilage in an area where it's been injured. And so just to talk about real quickly what platelet-rich plasma is, and people may have heard of this in the news, you may have heard of an NBA player going and get it. And basically it's blood that you take from yourself, from the patient, and then you spin it down in a centrifuge. And the idea is that you want to get the activated platelets, and that helps to release growth factors to induce healing and reduce inflammation. And it may also be cartilage protective as well. And so here's an example of a patient who comes to my office, and then here's their x-ray findings. And you can see where this little hole is on this x-ray, that's where the cartilage has been injured. And this is a CT scan, again, showing this chronic cyst, and an MRI, again, showing the cyst and the cartilage injury. So this patient is having pain, not only from the cartilage injury, but now because the fluid in the ankle joint has leaked into the bone and caused pain in the bone there. So the plan for this patient is to go in there with my video camera, and here's what it looks like in the video of me putting what's called an arthroscope into the ankle. And I'm clearing away, and you can see on these pictures here where the cartilage, it should be nice and beautiful and white like the top. And then as soon as you get in there, it's not. And this is where their injury has been, and it's filled with cystic fluid. And that's creating a lot of pain there. So the first thing I'll do is I'll put some bone graft from the patient in there, and then I'll follow that up by taking, sorry, the video just paused there, and taking your own bone graft, and then taking cadaver bone graft that I'll mix with your own stem cells, and then adding that on top of it, and basically creating a almost filling like a defect in a street. But this is a biologic defect that we're filling now. And so you have both your own cells, you have a scaffold of cadaver cartilage, and then the local growth factors to help stimulate healing. And there it is coming in nicely. And there's the defect filled in. And this is called using something called biocartilage, but the idea is that it's treating the cartilage lesion to help reduce pain here. And at the end of the day, this is something that will hopefully prevent or delay the onset of arthritis and get patients back to be active and enjoy life and be pain-free. So in summary, you see 3 different examples of 3 different types of injuries that come into my office very commonly that are sports related. And whether it's a 15-year-old high school player or a 67-year-old pickleball player, the injuries are all the same. It's just how we treat them is a little bit differently. But my approach is the most important is that I want to get you back on the court of life, and that is taking care of your family, your grandkids, or getting back on pickleball and enjoying your weekends with your friends. And that's really how I approach all my patients. And so it doesn't matter if you're an elite athlete or a weekend warrior, I really want you to get out there and do what you enjoy doing pain-free. So with that, I really appreciate everybody's attention and time. And if you need to get a hold of me, I'd be happy to provide my information to the chat box that we can forward to you all later on. And thank you again for your time today.
Thank you, Dr. Ferkel. We do have a couple of questions for you. Very first one. Hello, can you hear us?
Are you talking to me?
Yes.
Yeah, 2 quick questions. I had to step away for a minute, so I'm not sure if you covered this or not. But I have, I guess, pronated, I was told by my podiatrist. And I was wondering, is there certain exercises, if you have like, weak ankles, or if you kind of are more preventative so you can avoid some of these injuries? And then also, if you can kind of just touch on orthotics as well. I'm not sure that's the area that you oversee.
Yeah, so great question. So at SCOE, we actually do make custom orthotics for you, and I'm happy to see patients and provide those. The idea of overpronating is actually a very common thing that we see in patients across the age spectrum. And what that means, just to kind of clarify for the population, for the audience out there, it essentially means that your big toe side of your foot is starting to roll in. And so if this is your foot, you're starting to turn in this way and kind of walking more along the inside portion of your foot. And that's very common we see in patients. And oftentimes that can be helped corrected with good orthotics that are customly made for you, that helps increase your arch as well as give your heel some support. So I think that's one way to help support your overpronated foot. Also with good shoe wear. If you're a runner, you want to have shoes that will correct that with a pronation bar. And so if you go to a good running store like Fleet Feet or Roadrunners, or any place that has a runner's lane is very good in Valencia. And the idea is they'll watch you walk, watch you run, and they'll get you shoes that help support so you don't overpronate or oversupinate, which is the opposite of that. In terms of helping to support weak ankles, bracing does help, but we really don't want you to wear a brace too much because that will actually overdo it and not allow your ankle to get stronger. And so I think getting into physical therapy is very helpful for that as well. It's trying to identify, well, why are the ankles weak? Is it from a ligament, or is it just from something called more functional instability, which is your hip muscles being weak, your glutes or your butt muscles being weak? And so working on strengthening those as well.
Thank you.
Any other questions?
Thank you. We do have another question. Is it okay to wear ankle sleeves to stabilize weak ankles, especially when I'm wearing flip-flops? My ankles are wobbly.
I think, like I said, it's okay to wear a semi-supportive ankle sleeve or brace if you're being really active and your feeling ankle is wobbly or unstable. I don't want to rely on that though. So again, it's trying to figure out what is the etiology of this and kind of helping to address that. With flip-flops, I'm a huge proponent of avoiding very flat flip-flops. That will really aggravate your ankles more because it's going to cause you to overpronate more, really create people have pain along the inside of their ankle, create what's called shin splints occasionally, and just make ankles feel more painful in general, and may aggravate even your knee or hip problems too. So I really believe in having some good outdoor walking shoes that have good arch supports in them, whether it's a Birkenstock like shoe. And again, these are just brands out there that I'm not like a consultant for anything, but just Naot is another one. Any sandals that have good arch supports, you can go to the walking store, the mall, and get fitted for some there. But really flat flip-flops is going to really aggravate your ankle pain probably.
Thank you. Some awesome questions. I have another question for the doctor. Do you have an opinion on acupuncture helping ankle pain after sprain and fracture recovery?
So absolutely. I mean, I think acupuncture is a great option to help with pain relief. I'm a huge proponent of integrative medicine, which means bringing together both Western and Eastern medicine to treat the patient, because Western medicine doesn't have all the answers, as we know. And so whether that's using herbs or alternative modalities such as acupuncture, massage therapy, cupping to help with pain relief, I think all that plays a good role. And in terms of from an ankle sprain, it also can help something called dry needling, which is what an acupuncturist can do. Can also help relieve a lot of the pain as well. Our therapists aren't allowed in California to do specifically quote unquote dry needling, but acupuncturists can do those if they're sports medicine acupuncturists. So I think it's about finding the right acupuncturist who has the right training to help take care of these kind of injuries. But absolutely, I think that's something to refer to as kind of a complement to physical therapy and other modalities of treatment.
These are some amazing questions. Does anyone have any other questions for Dr. Ferkel? Feel free to raise your hand, use the chat. That was a great presentation. I love the videos.
Thank you. Oh, thanks.
Some people might not like the videos, but I like them.
All right. Well, I'm going to provide my my website as well as my phone number in case anybody wants to call me. Please feel free to get a hold of me. And just getting that for you guys right now.
Perfect. Well, while the doctor is typing that into the chat for everyone, we'll also have that on hand. If you just want to later give us a call and you didn't get a chance to catch the number or his contact information, we'll have that for you. So you can call us at ONEgeneration, our center, and we can get that for you. But thank you so much, Dr. Ferkel. Dr. Bawa is no longer with us here, but we thank him as well, and just everyone at Southern California Orthopedic Institute. We are so grateful, and we just appreciate everything that you're doing for ONEgeneration. Thank you so much for your time.
Thank you guys for having me, and have a great weekend.
You too.
All right, bye-bye.